So now we move to the second talk of Dr. Maria Vittoria Livraga, Head of Finance and Administration at CNAO, so my boss basically. She is dealing with costs of Hadrontherapy, the ABC analysis applied to operations in CNAO. Please, Maria Vittoria, you have 20 minutes. Look at the time.
Okay. So thank you. Thank you for this opportunity to present the work, this work about cost that now we are performing together with a small team of controller and together with the help of University Bocconi of Milan. So we will talk about cost and about an unusual method of cost accounting used to trace hadrontherapy costs. This is my agenda, the purpose of the study, and then the methodology, the results, a comparison with the Italian value of reimbursement, and final consideration and the take-home message. So let's start with the purpose of the study. We want to investigate deeply all the cost of the hadrontherapy, but passing through the activities that generate this process. And why we want to do this? Because we want to compare these values, the results, with the values that are stated by the government for the reimbursement. And then to monitor exactly what is the incidence of the research and of indirect cost on the overall cost of our organization. And then also it is useful to monitor if each activity has allocated the adequate quantity of resources. And then final goal, this is our final goal, is to relate the results in terms of cost with the benefits that are generated by treating patients with hadrontherapy. So what is the activity-based costing? Please allow me this out of context, simply and funny picture, but Professor of Economics used this picture to explain in a very simple way what is the activity-based costing method. There is a man who is making an action and of putting a pizza in a oven, and surely before making this action he would have prepared the pizza dough, and after this he will serve the pizza to a table. So there is a cost object, that is the pizza. There are some activities, putting the pizza in the oven, and there are some resources that are the labor, the person, that are materials, tomatoes and basilico and flour. And then there is a space, the cooking area. So passing through the picture to an equal, simple definition, activity-based costing is a costing system that focuses on activities and the fundamental cost objects. Costs are assigned to products based on the resources that the products consume in terms of these activities. In red are the three fundamental of the activity-based costing. So we obviously had to make some assumptions in our analysis. And the first one is that we perform the analysis in CNAO. And the fact to perform the analysis in a facility where there is a synchrotron providing both protons and carbon ions affected the results. And the base of analysis were the financial data, the 23 financial year data in terms of cost, revenues, and activities performed. Then we have to consider CNAO as a facility almost at his full capacity. We are now treating, in 2023, we treated 538 patients. And this is important because if we compare the results of our study with the results of more recent study, we can see that they are made on facilities in a ramp-up phase, and the results are different. And then we have a mix of 50-50 between protons and carbon ions. And as assumption, we made some interviews of the clinical staff and all personnel involved in the clinical paths in year 2022, and we revised them in 2023. So the starting point is observing the patient paths and identify some micro phases, micro activities, and some activities. The phases of the patient paths we identified the first one as the enrollment, then the treatment delivery, and then the follow-up. Within these 3 phases, we have identified 74 activities grouped in 10 macro activities. I make a quick example. For the simulation is macro activities that include, for example, as activities ATC for simulation or MR or preparation of a mask for immobilization. And then once identified the activities, we have to talk about the resources. The resources are the common resources to produce a cost object: personnel, equipment, spaces, and then materials or direct services. And all these types of resources are as a value determined as a full cost. That means that, for example, for personnel, not only salary and social charges are included in the cost, but also, for example, cost of personal insurances, cost of training, cost of personal equipment, and also cost of the space that a person using now to perform his day-by-day work. For the equipment, not only the cost of the depreciation, but of the equipment, but also cost of maintenance. And for example, personnel involved in the maintenance service is not in the personal cost, but within the cost of the resource identified as equipment. The same is for the spaces, while for materials, the value is determined on the base of the purchase value. So we have resources, we have activities, and then we have defined our cost object. And for us are the item described below: the carbon ion treatment standard, a proton standard, a carbon ion boost, proton booster, proton pediatric, proton eye melanoma, the follow-up, and then cost objects related to patients not enrolled and the patient that go in break without completing the treatment. Oh, I did something. Excuse me. Okay. Okay. Now, how resources, activities, and cost objects are relating each other. This two table, explain how it works. The table above shows how to determine the cost of an activity. We have the description of an activity. We have all the items of cost that are included in this activity. We have an input, the description of the time performed, an input in terms of time, a unitary cost associated, and then a final unitary cost of the activity. For example, if we consider the evaluation of a patient coming from the service, the patient's contact point, we see three rows on the above table with associated 3 different cost items, for example, clinical administration, radiotherapist, specific task associated, an input in terms of time, a correction factor that represents the probability of occurrence of that task for those activity, and finally, multiplying all the factors, the unitary direct cost of the activity. We find the same activity moving to an upper level. In the treatment type, it is the first line, the evaluation of the case of a patient coming from the contact point, where 2 other factors, which are the probability of occurrence, the repeatability of the activity, are defined to arrive to get the unitary direct cost within the standard carbon ion treatment of the process of evaluation. Okay. So, to resume, the unitary direct cost of an activity is a sum up of all the costs of the items that compose that activity, and the unitary direct cost of a treatment type is a sum up of the costs of all the activities that compose the treatment type. And if you multiply the unitary direct cost for each treatment type by the number of treatment types performed in year 2023, we get the total value of the direct cost of our organization in 2023 absorbed directly by the treatments. And this amount do not explain all the cost of our organization, but represents only the 50% of the cost of our organization. And so we had to state some drivers to allocate the remaining costs. For example, in addition to the 50% of the costs traced by the activity-based costing, we had other clinical costs, which were costs related in any case to the clinical activity, but could not be traced by the ABC. For example, some costs related to specific activities of dosimetry or etc. And that represents the 15%. We had to choose some drivers to allocate this and to allocate also the residual indirect cost. And the driver could be one organization can choose his own driver, which is the most appropriate, but we could choose among the number of treatments or the number of sessions or the number of activities or events related to each treatment type. And we have chosen the last column of the table on the right, that is the number of events related to each type of treatment type. So what we can see is the incidence of the research that is composed by the clinical research cost that is 7%, and non-clinical research direct cost is 15%. So we get 22%, while the impact of indirect costs is in any case high because it's 14%. This graph shows the impact in terms of percentages of the different type of resource within the different cost objects. The orange column represents the equipment, and this is an obvious result considering that we are using the synchrotron, while and it is much higher than personal, that is in blue, while it is more well balanced in the case of the pediatric patient, in reason that a pediatric patient involves a more in terms of personnel for assistance to the child. So if you now we arrive to tell how the money of the results and to try to explain some comparison with the previous studies. For CNAO, as we told before, the results are affected by differences among the facilities where the studies are performed. For example, in CNAO, we have 3 treatment rooms. We have protons and carbon ions, and we can be considered 90% of our full capacity. The direct cost of a treatment coming only from the activity-based costing varies from 8,000 euro for eye melanoma to 32,000 euro for proton pediatric patient. If we shift from the cost traced by ABC to the full cost of this procedure, this increases from 60,000 for eye melanoma to 52 for a pediatric patient with protons. A previous study, 2014, was based on a facility with 2 treatment rooms, multi-particle center at full capacity, and the values that you see on the right are based only on cost traced by activity-based costing. So it is not explained. We cannot see the incidence of indirect costs, could be more higher. and it varies from the lower it is. And this study of 2014 introduced also a difference between private initiative and public sponsored center, and it varies from 6,000 euro for a carbon center public sponsored to 46,000 euro for a multi-particle center with a private initiative. More recently, this is a study in Holland was performed. One treatment room, proton center in the ramp-up phase. So there is the potential for going on in the future years for economies of scale, not full capacity, and full costs, so including also indirect, varies from 12,000 euros for eye melanoma to 89,000 euros for head and neck cancer. In any case, in all the papers and the literature, proton therapy is always estimated to be 2-4 times higher in terms of cost than conventional radiotherapy. So, which are a quick look to the differences among the studies as a situation. What they are due to the equipment choice, we already told before. The depreciation, for example, because for a center like CNAO that was public funded for the construction, according to our local accounting rule, depreciation are calculated on the residual value of the asset, deducted the contribution received by the government. That means that the depreciation, if we think that CNAO is almost for the overall cost of the construction public funded, our base for calculate depreciation is low, and this is significantly different from a private initiative. Also related for depreciation, different rates can be used in one country compared with another. And for example, interest, if we pass through from the level of ABC to a level of allocating indirect cost, interest on a bank loan. If we have a bank loan, obviously the cost is higher. And then the last question is, the analysis is performed in a standalone facility or a facility close to an hospital? This is a good question, because if we are the facility is placed close to an hospital, there is a possibility to exploit synergies. If it is a standalone facility, as it was the goal of now, there should be other advantages, for example, to be at the disposal of a network of all oncological hospital in the region. But this is a hot subject of discussion. So, let's go to compare the results of our study in terms of cost with the fees of reimbursement that will be valid in Italy starting from 2025. This is an official document of the government, is what is stated for Hadrontherapy. They identified only 3 codes for Hadrontherapy, that is the stereotactic with the fee starting from 2025 of 11,000, boost till up to 6 fractions, and Hadrontherapy only they mention entire cycle, which is 21,600 euros. This is a comparison with the result of our study. So, first of all, we had to relate our cost objects to these 3 codes. So, there is no distinction between carbon ions and protons. And in addition, there is no mention of complexity. There is only this mentioning of fractionment, and so to the code 9229U, which is most of the treatment that we perform in CNAO, the entire cycle, we used to compare the carbon ion full cycle, proton full cycle, and the pediatric patients. So compared to a cost that can be up to 52,000 euros for the pediatric patient, we get a reimbursement of 21,000 euros. And the same is for the other treatment, but this is a higher difference that we can see. And as final consideration, so the hot question is a standalone facility or a facility close to an hospital. And an improvement in patient number surely can help to lower the cost in terms of indirect cost because they are allocated on a higher number of patients. But reducing improvement in patient number means reducing our time of treatment, and this can be against the scope of the hadrontherapy that frequently treats complex patients. Then the cost of the synchrotron and the machine is at the base of the results, both for protons and carbon ions. So surely, if we would have performed the analysis with considering the gantry for protons, the cost of the proton therapy would be lower. And there is a need to include complexity in defining the public reimbursement values. About the methodology, ABC helps in tracing the absorption of the resources by core and non-core activities, and for the facilities under construction or under phase of development are a useful method to determine to dimensioning the requirement in terms of personnel cost, and gives important information that are useful but not enough to negotiate adequately the value of reimbursement. So if you are interested in going more in deep in this topic, or if you want to develop your own activity-based costing, we'll leave some bibliography after the presentation. Here is a useful bibliography, and if you want, we also can help. Thank you.
Thank you. Thank you, Madam Vittoria. Questions? Many questions. Pavel. Or Maurizio, the closest one. Why not?
Okay, so thank you very much. So very interesting. I mean, when I see numbers, I like this kind of presentations. I have two questions. The first is that in one of your slides, you say cost of treatment without distinguishing between protons and carbon. And then in a table, 2 slides after, you show that there is a small difference between protons and carbon. There is difference, there is not difference, and what is the reason? Is the operation of the machine or?
Yes. Okay. Yes, we said cost of treatment, but then we identified in the process of constructing the framework of the activity-based costing, we have to define some cost object, because when we see how the processes of developing the patient paths is different, we see that maybe we need to define that some cost object, one different for another. For example, the carbon ion has traditionally 16 fractions treatment, and so we define it as a cost object. So for the cost object carbon ions, it has his own activities associated with the coefficient of repeatability of each one and the probability of occurrence. The proton treatment has his own, it is like composing a bill, in industrial terms is a bill of materials. Okay. You identify the cost object, it is a final product, and you build your bill of material specific for that cost object. So if you want to, you could also trace, choose, for example, to identify a cost object like treatment with gating system. We could do it, identify a specific cost object, and then have the results. But we did not, because the probability of using the gating has been considered as an event that eventually could happen at the moment. While pediatric patient, we decided it was our choice to trace individually.
Okay. You are receiving about 60% of your cost. Yeah, that's the situation. Of course, there is a part of depreciation cost. Yeah, so of your instruments, so there was the primary investment, so on. But in principle, how you are able to survive? Yeah, with that, you are not printing euro in the basement.
It's not yet.
Okay, Sandro, I will answer if you want to ask, because it's a yes, it's a teacher. Okay, yeah, when CNAO was created by the Ministry of Health, the law stated to finance the construction of the center, and then there was a law that ensured, starting from a certain year after the construction, a lump contribution to cover the extra cost mainly generated by the Carbon Ion Center and of the related to the research activities. So there is a law of the state that is renewed year by year that state this lump sum and that covers the remaining part of the cost.
So, thanks, speaker again. And now we move to the third talk.
Just one more minute, please.
Here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.